Hello, everybody, and welcome to our next Medicine for Members talk. We are very lucky this evening that we are joined by Mike Moore, our chair, to host this evening's lecture. So, Mike, thank you so much for joining us.
Thank you very much, Nikki, and good evening, everybody. And I was going to say it's wonderful to see you all. I can't see you all, but I hope you can see us. And it's really good to be able, again, to have Medicine for Members in this new format, which I hope you find helpful. And I'm sure you're going to find tonight's briefing from Jean very helpful and informative and stimulating. So thank you for joining us tonight. So as Nikki said, I'm Mike Moore. I'm the chair of Cambridge University Hospitals, and membership of the hospital is vitally important to us. So we're joined tonight by Dr. Jean Abraham from the university, and Jean is Reader in Precision Breast Cancer Medicine and is a very highly respected member of Cambridge University Hospitals and the university, and I know is wonderfully well respected by both her colleagues and by patients here in the hospital. So we're delighted to have Jean for a presentation tonight. Jean's going to talk to us for about 20-25 minutes, and then when Jean's finished, we'll have the opportunity for another half hour or so of conversation, hopefully prompted by any points or questions that Jean's talk raises with you. So Jean's going to focus on the research, leading edge research of various types and clinical trials so that we are able to deliver more precise treatment of individual patient needs, and some key words in there such as precise. So Jean, I'm going to hand over to you to run through your talk. So good evening, Jean.
Hello, everybody. So the first challenge is to share screen. So hopefully. Can I just check? Yeah, everyone's happy with that. Good. So thank you for asking me to come and do this talk. It's a real privilege, and I've called it Precision Breast Cancer Medicine. What is it and can we achieve it? Largely because precision medicine is one of those terms that's used a great deal and perhaps isn't always terribly clear what it means. I'm going to talk largely about the setting of early breast cancer and how we are changing precision breast cancer treatments in that setting. But some of what I say would also apply to later stage disease as well. So hopefully we'll start, I think, by defining it. So I think just so that we are all on the same page, precision breast cancer medicine. So what is it? It's often used interchangeably with terms like personalized or individualized medicine. And it usually refers to adapting treatment recommendations for a single patient, for an individual, based on their inherited characteristics of the patient, the molecular characteristics of the tumor or the cancer, the time points of the treatment, the risks and benefits of the treatment, and the patient's preferences, other medical conditions and lifestyles. Less so about the last point, but probably more about the first points at the moment. I'm going to start though, because Nikki has very well informed me that there's a broad spectrum of people listening. So I'm going to start with some really basic stuff. So for you international breast cancer specialists, I apologize. But so breast cancer staging, this is a very simple version of it. As you can see, the normal breast is shown in the top left-hand part of the picture. And as the stages go through, at stage 1, you can see there's a small tumor within the breast, and the lymph nodes that you find in the armpit are not affected usually. Each of these stages can be broken down into more subsections. Stage 2 is where either the tumor is larger and or it's a similar size, but there are more lymph nodes involved. And stage 3 again is larger with more lymph node involvement. There is also something called inflammatory breast cancer, where there is no actual lump as such that you feel, but the skin feels like it's been infiltrated with lots of cells that make it feel very hot and red and often hard to the touch. So those 3 stages are the area that this talk is largely going to focus on. And stage 4 is the more advanced form of breast cancer, where it has spread from the breast and the armpit area to other organs, and at that point is not curable, but we manage the treatment with different types of treatment. 55,000 breast cancer cases every year, so that's about 150 every day, and so breast cancer is the most common cancer in the UK. In men who also get breast cancer, there are about 390 new cases in 2017, and which is an approximate number for most years. So that's not very many, it's less than 1%. But the number of deaths from breast cancer is about 11,500. And in terms of the percentage of all cancer deaths, it's about 7% of all cancer deaths. Happily, the mortality or the number of people dying from breast cancer is reducing over time because of screening and because of better treatments. But what you can see in the little box with the staging is that picking up early cancer, breast cancer early, so early detection, and the detection and early treatment of aggressive breast cancer is critical. Because from stages 1 through to 3, you can see that 70% or more of patients can be cured and can survive for 5 years or more. But at stage 4, obviously the survival is much worse. So diagnosis is usually done either because the patient finds a lump or because there is a mammogram screening process that has found a lump on behalf of the patient. So for those that come having found the lump themselves, they go to their GP and then they are referred to the urgent cancer clinic where we will do mammogram, ultrasound and biopsy, which will allow us to understand whether the lump that's been found is cancerous. And it also allows us to look at the histology or the type of breast cancer it is, the grade or how aggressively it's turning over, and then certain markers such as estrogen receptor, progesterone receptor, and HER2 protein. And these are factors that will come up throughout the talk, and they're quite key to deciding what kind of treatment you get. All this information goes to a multidisciplinary team meeting where there are cancer specialists, in imaging, pathologists who look at the tumour under a microscope, surgeons, our genetics department get involved, and additional support from radiological assessment can be done as well. We agree a treatment plan, and then that's relayed to the patient through their clinician. So in current standard of care practice across the UK, the key sort of biomarkers, if you like, the key markers that we use to decide breast cancer treatment are estrogen, progesterone and HER2. What you can see at the bottom of this slide is that we stage the patient. So we will have a look, sometimes doing CT scans, but sometimes just doing ultrasounds and MRIs. At how far the cancer has spread, and then we will look at the broad subtype, and we can use standard pathology or more sophisticated molecular pathology such as fluorescence in situ hybridization, and that allows us to categorize our breast cancer into several different categories. We then use decision-making tools, and this is a decision-making tool called Predict, which is freely accessible on the web, and you can see the website address at the top of the slide. And what we do is we plug in the key features that we think are important for deciding what the risk of the cancer coming back post-surgery is for this particular patient, and we make a treatment plan based on the level of risk involved. Largely, the treatments that we have are categorized into local therapy and systemic therapy. Local therapy being to try and prevent recurrence of the disease where it began. So surgery will remove the disease from the breast, and radiotherapy will prevent local recurrence of the disease either in the breast, the armpit, or just above the clavicle. Radiotherapy does also have an overall survival benefit, but its key effects are for local therapy. But of course, what worries patients a lot is whether the cancer has spread beyond where it started and is secretly spreading without knowing. And so for that kind of systemic spread, we use chemotherapy, hormone therapy, and targeted therapy. And I will come back to what I mean by targeted therapy shortly. And obviously, in the early breast cancer setting, we are hoping to obtain cure. So probably in the last 15 to 20 years, some of the work done by the breast program here and Carlos Caldes's group has shown that breast cancer is not a single disease, and that actually what we really need to understand are the different subtypes of breast cancer and how we need to manage them differently. So intensive treatments for high-risk breast cancers, 25 to 30% of which will often recur, often within the first 5 years, and also how to avoid unnecessary treatment in low-risk hormone-positive patients who don't really need extensive chemotherapy to stop their disease coming back. So in general, a one-size-fits-all approach is simply not good enough. So this is probably one of the more complex slides that I've got in this talk, and I'm going to walk you through it. It's really quite straightforward. It's called a Kaplan-Meier curve. And what you can see where I'm pointing at the moment is where it says 1 is where all the patients that are in this study are alive. And on the x-axis, over time, what you'll see is different numbers of patients will die. And on the y-axis is time. So what we're really looking at is, in this study, how many patients did not survive over a period of 150 months. So the reason to show you this is each of these different coloured lines is a different subtype of breast cancer by a new classification that was developed by the Caldas group in Cambridge. And why this helps us is, in the clinic, what we can see are those 3 broad categories of ER positive, HER2 positive, and PR positive patients, so estrogen, progesterone, HER2 receptor status. But often what we see is that some estrogen receptor positive patients do very well. So over a period of nearly 8 years or longer, in fact, not very many patients from the start have died because of their breast cancer. However, what we can see down here is the green line, which is also estrogen receptor breast cancer patients. And the problem here is in clinic, you can't tell the difference between these 2 groups of patients. We also can see that there are some patients on the turquoise line who obviously have lots of immune cells involved in their breast cancer. And we have on the purple line here a group of patients whose cancer is very aggressive in the first few years, but then if they get through that period, it actually doesn't seem to affect them at all. And that's the triple negative cohort. And we're going to talk about that cohort in a minute. But the last group that I want you to look at is the very worst line that seems to do the worst. And these are the patients who are HER2 positive. And this is before a treatment called trastuzumab or Herceptin. And Herceptin or trastuzumab is a targeted therapy. So in the mid-1980s, a mutated gene was discovered, which was present in breast cancer, in certain breast cancer patients and breast cancer cells, which increased the aggressiveness of that breast cancer. And the hypothesis was that if you could target this pathway or that particular gene, that you could actually block off that activity of the gene and prevent the aggressiveness of that cancer. And so a trial was done using what's called a monoclonal antibody, so an antibody or a drug that just targets a very specific point in that pathway. And what it found was that patients who received that drug did very much better. So fewer of them died from the start to 5 years later, compared to those that did not receive that drug, where you can see a big drop-off of patients who didn't survive. So the other thing I want you to take note of here is that the gene was discovered in the 1980s, but it took till the late 1998 and near 2000s for this drug to make it into the clinic. So that's something that we've really got to change, that speed from discovery to being in the clinic. And now, of course, we have more sophisticated versions that we give alongside or instead of this drug. So I'm going to bring you to the research that we do in Cambridge now and how we've brought genomics and clinical trials together to advance precision breast cancer medicine. And you can see by all the different logos on this page that this has been supported by a number of institutes and funders, and I will highlight one of them in particular, ACT and Cancer Research UK, who have funded a very large part of this work, along with AstraZeneca, who've provided some of the drugs. But before we get to that, I just want to focus on the key questions that patients are often most concerned about. And I want you to think about those as we are talking about how these new studies are helping ask and answer those questions. So patients are often very concerned about what is my risk of relapse or death, i.e. will I be cured? What is my best treatment or management option? What are the likely toxicities, both acutely as I'm getting the drug and in the longer term? How can I know early if a treatment is working or not? Do I need any additional treatment or surveillance after the first treatment is finished? And are any of my family at risk? For me, those 6 questions are probably the prominent questions that patients usually want to know the answers to. So I'm going to tell you about something called whole genome sequence, because that's pivotal to one of the studies that I'm going to talk about called the Personalised Breast Cancer Programme. So whole genome sequencing is the process of reading the human genome. So what do I mean by that? So I want you to think about a book. So when you pick up a book, if you just read the chapter headings, you'll get a very reasonable idea about what the kind of story is behind the book, but you won't really understand the depth and nature of the story the book is telling. Similarly, what we used to do was just take a panel of genes that we thought were interesting for a particular cancer and look at those genes in a quite detailed fashion. That gave us some idea, but we lost a lot of the crucial detail by looking in much closer inspection at the genome. So what whole genome sequencing does is it reads the genome in much greater depth and the sequence of the different parts of the genome. What makes cancer tricky is that we have 2 genomes if we're a cancer patient. So we have the somatic genome or the tumor genome, which is what's changed since the tumor developed. And then we also have what's called the germline genome, which is what has actually, what we came into the world with, so what we inherited from our parents. And what we look at in whole genome sequencing is whether there is, what kind of changes there are, whether there's too much or too little of specific genes, or losses or gains of particular regions. The problem with this is that it gives us a huge amount of data. It's also a good thing, but what we need to learn to do is to decipher the signal from the noise. So what is important in all that noise and what is not important. So the Personalised Breast Cancer Programme takes that technology of whole genome sequencing, and for patients with either early stage, so curable cancer, or with late stage, so incurable cancer, and it consents them if they wish to be consented. And we take a blood and a tumour sample and we do the sequencing of both the blood and the tumour. We read their genome in depth and we look at anything related to breast cancer, and then we bring out those things that we know can make a change in the treatment of breast cancer, and we discuss them in our oncogenetics review or oncogenomics review board. If there's anything important that we think we can clinically action, we then double check it through a process called validation, and then that finding is sent back to the clinician and to the patients. So we look at a range of different things: mutations, risk of cancer, toxicity to drugs, risk to family members, how much mutation there is in your cancer. And then we look at the personalized treatment that we can provide from this. So can we find you a matched therapy? Do you need to have prophylactic or risk reducing surgery? Do your family need screening? Can you go on a trial? Is there other cancers that you need to be screened for? Do you need to be referred to clinical genetics? And many other things. So that's the whole genome sequencing project, and we marry that project with our clinical trials. And I'm going to give you an example of one of the largest clinical trials in our breast cancer portfolio, which is running in 29 other UK centres, and we're opening it abroad as well. And simply put, this is a clinical trial for triple negative breast cancer patients, so patients who do not have receptors for estrogen, progesterone or HER2, and also for patients who have a hereditary type of breast cancer. And we give these patients their either chemotherapy or chemotherapy plus a targeted agent before they have their surgery. So the tumor is still in their body and we can monitor the response to therapy with scans and biopsies and many, many other ways of testing that. So as I said, triple negative breast cancer, they don't have any of the three markers that we look for normally. It's about 15 to 20% of all breast cancers, and there's some biological behavior activity overlap with hereditary breast cancers. We normally just treat it with chemotherapy, and we assess how well someone does with upfront chemotherapy by seeing how much tumor is left in the surgical specimen. And how much tumor is left in the surgical specimen can actually reflect how likely someone is to relapse or die from their cancer going forwards for triple negative breast cancer patients. So I'm not going to go into this in any detail, but this list on the left-hand side are a list of all the different types of specimens and investigations that the patients that come into Partner and the Personalised Breast Cancer Programme allow us to take as part of their treatment. It is always remarkable how much patients are willing to help other patients by coming into this kind of research. And actually the Personalised Breast Cancer Programme itself was very much funded by patients who took part in the BRA Code project to fund that programme as part of the ACTS fundraising process, and by many other donors who may be members of this meeting today. So I'm going to give you an example of how we have taken patients who have gone into Partner and into the Personalised Breast Cancer Programme, and we have combined the trial and the sequencing findings to change their management. So here we have a 69-year-old lady who at 69 is too old by UK genetic guidelines to be tested for things like BRCA. She did not have a significant family history. And so she came into the sequencing project, and when we looked at her genome, she had what we call a hypermutated genome. So she had many, many more mutations than we would have expected for a standard breast cancer patient. This made us look at a particular type of pathway. And in that pathway, we found that she actually had in her inherited genome, so what had come from her parents, she had inherited a deletion of a very important gene. And that gene is actually more commonly found in patients with colorectal cancer. So in fact, this lady is not only at risk of breast cancer, but she has quite a high risk of colorectal cancer. So the impact for this lady by coming into the sequencing project alongside the Partner project was that we could reassure her that she'd got good treatment. She responded extremely well with no tumor left at surgery. We could tell her that she wasn't going to get toxicity from some of her drugs. We also know what we will give her as her first line treatment if she relapsed, which would be immunotherapy. And we screened the rest of her family to check if they had any of these high risk genes as well. So that's a big impact for coming into those two projects for this one lady. From a scientific perspective, what we can also do is take patients who look very similar to each other. So here are 3 hereditary breast cancer patients, all with early stage breast cancer, all with rapidly growing breast cancers. They got different types of treatment when they were randomized into the Partner arm, and you can see the 61-year-old on the left-hand side got the targeted agent and chemo, the other 2 did not. By week 9, so by 3 cycles into the treatment, we can see that we have their molecular profile. So we can start to see what the differences are between these patients while in fact they are being treated. And when we get the outcome at surgery, what we can see is that the patient who got chemo and olaparib did very well, had no tumor at surgery, but then actually so did one of the patients who did not get it. But then the 25-year-old who also only got chemotherapy did very badly and actually had a lot of tumor left at surgery, which meant she had a very bad prognosis. So we can start to pick apart what it is about these patients that's different, even though superficially they look very similar. So this is a comment from a patient who was sent to me as a second opinion referral, treated elsewhere outside of both the trials that I've just talked about. And she'd had upfront chemotherapy and she'd had a lot of tumor left at surgery. And she was a smart woman who was a former scientist and knew exactly what this meant. And this was what she said: "I know I have a really bad outlook. I feel like there's nothing I can do about this. There just don't seem to be any treatments available once you've finished chemo, surgery, and radiotherapy. Every new drug seems to take forever to be available for me and people like me, and I'm worried it will come too late." So one of the beauties of being a clinician who does research is that you can really hear your patients and bring that back to the clinical research environment. And so we went back to the partner trial and we decided to implement a poor responder sub-study. So now if you get to cycle 6, which is the penultimate cycle of partner, and you haven't responded, in Cambridge, and this will open in some other centres in the UK, you have the opportunity to go into a sub-study where you get novel agents that you're not able to get anywhere else in any other study in the early breast cancer setting, in this type of setting, and you get those treatments for 8 weeks. And what we hope this will do is that we will push these patients into a complete response at surgery. And why this is important in real time is this is the case of the 25-year-old that we saw. So she came into, so she was a poor responder to chemotherapy. She came into the sequencing project and partner. We did a lot of preclinical modeling work on her in collaboration with the Caldas group. And we looked at some new treatment options. And some of those are now in that poor responder sub-study. So what we have now is a patient, the most recent one was probably about 5 weeks ago, who again got the chemotherapy arm of partner, didn't seem to respond. And when we looked at her sequencing, we could see that she was actually very likely to respond to a particular type of treatment. She's now getting that treatment. And what we hope we'll see at surgery is that no cancer will remain and that she'll be alive and disease-free in years to come. So we can feed that back to you over time. So patients in research really help other patients' journey. So these were the questions that we were asking at the outset, and I think we can show that we have started to answer many of these in terms of risk of relapse, best treatment options, likely toxicities, is the treatment working, is my family at risk of cancer, etc. But we need to do more, and what we need to do is really start to bring the research environment into the clinic more quickly and in real time. So the CRUK Cambridge Cancer Centre has a theme called the Integrated Cancer Medicine theme, run by a number of us, but led by Richard Gilbertson. And in this, we are integrating all the different streams of research that we collect during a trial like Partner, and we're trying to do it in real time to affect patient care. And what we're trying to understand is which of those components are most important to patient care. So, precision breast cancer medicine, can we achieve it? Yes, but there's still much more to do. We need to detect cancer earlier and diagnose it earlier. We need to understand when a patient is responding to treatment earlier, and some of our novel imaging studies will really help us to do that so that we can avoid unnecessary toxicity. We need to be able to assess the risk of relapse and death over time using novel biomarkers and find effective interventions. And this last bit really is geared towards the new the Cambridge Cancer Research Hospital, because collaboration with people outside of the standard medical specialties will really help us to find innovation and make these aims come true. So that co-location in the new hospital will really, really make a difference to making that innovation part of our standard of care. And these are just a few of the people who have done the work that I've presented today. That's it.
Jean, thank you very much indeed for a hugely impressive and very helpful talk, and a very clear talk. So thank you very much indeed. Just a couple of points, if I may, and then I'll ask Nikki to just advise us all on how to engage in the conversation and ask questions over the next few minutes. But just before I do that, Jean mentioned at the end of that talk the Cancer Research Hospital, and we're very excited about that. And I just want to make sure that all members are aware that together with the Children's Research Hospital were both given very specific go-ahead by recent government announcements. There's more to do to complete the financial package, but we're very much encouraged about that having now taken a major step forward to fruition. So, you know, that's terrific and important news. The second point, which is just a point really from my point as being the chair of the hospital board, the board through the last, 9 months now or 8 months has been very exercised by the fact that with COVID around, people have been very nervous about coming into hospital, and we have seen delays in presentation and in some cases delays in treatment. And that's not unique to us here in Addenbrooke's. It's true in hospitals and medical presentation up and down the country and indeed across the world. I want to reassure anyone watching that please, if you have concerns in regard to, is it safe to come into hospital? Can I get diagnosed? Please do present yourself through the normal channels in a normal way. We have worked enormously hard to try and make sure that we are able to maintain continued patient treatment through this period, and also to preserve the safety of patients while they're in hospital by different streaming of patients in different clinics, by avoiding and reducing the number of visitors into hospital to prevent cross-infection. So we have worked really hard, and one thing that's very different as we approach a second wave of COVID is our determination to continue to maintain services to non-COVID patients at the highest level we can. It's not straightforward. There are backlogs. We are very much aware of that, but we are working very hard at that. So please, my message to you would be that we are wanting still to provide those services to you as non-COVID patients, and that it is safe for you to present yourself to hospital. So, Nikki, do you want to help everyone in regard to how we're going to now conduct any questions, answers, and conversation?
Yes, thank you, Mike. And Jean, if you wouldn't mind just stopping sharing your screen, and then we can all see our faces and have a nice chat. So what we're going to do, as usual, there are 2 ways of commenting and asking your questions. The first is for those of you who have joined us through the webinar and on Zoom. There's a lovely Q&A box at the bottom of your screen. If you click on that, please just pop your questions in there, and we can begin to answer them. Otherwise, for those who have joined us via Facebook, I can see all your comments in front of me, so I will be reading them out to Mike and to Jean. So please do pop your comments on there. Okay.
Thank you, Nikki. So, Nikki, just while Jean, can I ask a question? Just while we're waiting for those who are watching to put in questions. I've been often been asked in other contexts, not just in the context of breast cancer, but other conditions as well, the following point, which is precision medicine and whole genome sequencing. Like, does that give any? Largely, your talk is related to the patients who've already presented and have already been detected as having the disease. And some people have asked the question, is there a further stage that we can see emerging where we're able to predict that an individual might have a propensity to have the disease? I mean, statistically, we could say, well, this condition applies to X% of the population, therefore one has an X% chance of succumbing to that. But that's not necessarily a valid argument, because different people will have different propensities. And therefore, in terms of precision medicine, people want to know how likely it is that I, being the person I am with my genetic makeup that I have, to be succumbing to that. What's your sense of how precision medicine is going to develop in that way? And I recognize that's not what you've been talking about. You've been talking about those who have already been detected as having the condition and how you can treat them. But that further step, what's your sense of that?
I think some of that is already happening. There are studies being run by Paul Farrow and Fiona Gilbert, who are looking at taking screening, for example, and nuancing it more with risk predictors for breast cancer. So that kind of precision medicine, where you're trying to bring in the genomics alongside the imaging to change how you screen people based on their potential risk, is beginning to happen. I think at the moment whole genome sequencing is still too complex and too expensive to say, well, let's just do that for everybody. And I think it's a bit like saying, well, let's just CT scan everybody. I think there's a risk-benefit ratio to be had and a cost-benefit ratio to be had. But I think certainly in the imaging, and I think somebody had a question about MyPEEBs and braids, they're both imaging studies that are looking at early detection and using genomics for that sort of situation.
Okay, thanks, Jean. So, so we do have, as you said, some questions. We've got 2 questions up so far, 3 questions as I'm watching. So there's Nikki's question, which you've kind of addressed, was how does the MyPEBs project fit into all this? And then I'll pick up Sean's question as well, and then and then I know Roy we've got a question as well for. Sean's question was, although male cancer is a very small percentage of overall breast cancer patients, what percentage of male patients diagnosed with breast cancer are BRCA positive? So we're going to type the answer to Nikki's question, but Jean, do you want to answer Sean's question?
Yeah, so overall, the number of patients who are BRCA positive, whether female or male, are only about 5 to 7% of an unselected population in the UK anyway. And so of the male population, I don't have at my fingertips exactly what the percentage is of BRCA positivity in the male cohort, but it will be I would imagine it will be relatively large because the number of patients who have male breast cancer is small. So of those, a proportion of those will be higher in relation to the female. But I can come back to Sean with specific numbers on that.
Okay, thank you, Jean. And I should say that, if there are questions that we either answer incompletely or we don't get round to answering, we will do our very best to make sure that we pick those up and come back to those questioners later in the meeting. And I'll ask, and Nikki will just remind us how that will happen at the end of the session. So rest assured, if we don't answer every question, either completely or at all, we will endeavour so to do after the session. So then we've got a question from Roy Swain. Good evening, Roy. In a previous meeting, we heard about fantastic algorithms for analysing brain tumour scans prior to radiotherapy. And in view of the complexity of the parameters in breast tumour assessment, are there similar algorithms under development for this condition? So, Jean?
Yeah, yes, no, I think that's an excellent question, and actually the integrated cancer medicine theme deals very much with that kind of area. So Kevin Brindle, Evis Sala, Ramona Wotek, Ferdia Gallagher are all part of our imaging team, along with Fiona Gilbert, who deals with the NHS side as well. They're all members of a team who are involved in integrated cancer medicine, and what we are doing as part of that is picking apart the raw data, if you like, for imaging, and trying to combine that information with the clinical data, with the genomic data, to understand what we can learn from imaging at different time points. And again, that involves developing combined data stream algorithms. So that's very much what we're doing here as well. And that's part of the integrated cancer medicine theme, which I haven't talked about today, mainly because of time, but that's a very prominent part of our work.
Thank you, Jean. We're still waiting for other questions to come in. So just let me, Nikki, have you got any others coming through?
Well, I've got quite a few on Facebook, so I can read out a few that we've got from Facebook. So from Charlotte, she's asked, are you, and I assume she's talking about the special sort of extra bits that we're doing in Cambridge that you mentioned. Are you offered entry to these, or do you have to be aware of them and request entry to acquire these treatments?
So for the personalised breast cancer programme, which is what we call an all-comers, so any stage of breast cancer, you just have to walk through the door in the Cambridge Breast Cancer Research Unit and be diagnosed with breast cancer, and you would be potentially offered it. And the other criteria for entry would be that we can actually be able to get a piece of tumour tissue and take a blood sample. So beyond that, there are no, and psychological well-being, etc. Beyond those sort of restrictions, there's no other requirement. And we hope to open this in about 3 or 4 other centres, at least, possibly more around the UK, and potentially elsewhere as well.
Okay, and then there's one from Julia. Huge advances have been made over the last 20 years in terms of 5-year survival. Are survival data being collected for 10 and 20 plus years past treatment, such that there is a baseline against which to measure the added benefit of precision medicine versus standard chemotherapy in terms of increased or longer term survival?
Yeah, I think most trials now routinely will collect out to at least 15 years, some for even longer. And you will periodically see relatively what's now regarded as older trials updating their survival statistics in journals to say, what would be considered more standard treatment, chemotherapy-based treatment. So yes, we do have that, and there is a very large collaborative piece of work done in Oxford, which is the Early Breast Cancer group that set up and run and publish meta-analyses of all of these studies, so we get that data as well.
And then Jenny North, who tells us that she's actually being treated at Addenbrooke's currently. She wants to know, can it ever really be cured, and what is the survival at stage 4? And then she was also told that that cure isn't really a term used. Preferred term is no evidence of disease. So I think she just wants to comment on that.
Yeah, so there's a lot of questions packed into that. So I mean, I guess I have seen patients who have had disease come back after many, many years. So I can understand why whoever said cure is one of those terms they're not comfortable with. I can see why they said that. But the statistics for different subtypes of breast cancer give us an idea of when someone is most likely to recur. And so we tend to say that beyond, for example, with triple negatives, after about 5 years, the chances of the disease coming back are much less. I agree with that hesitation to say cure, but I think what I found with patients is that many breast cancer patients, it takes them a long time to forget about the disease. So even they don't really feel that cure is the word that they hold on to. It's more being disease-free and not having the disease present. Just remind me of the other parts of that question as well, because there were quite a few things.
Sorry, so she just wanted to know, can it ever really be cured? And what is the survival at stage 4?
So I think I showed the survival at stage 4 earlier on, and it's slightly dependent on the subtype and how aggressive it is at presentation. So, but broadly speaking, that survival is from the data taken from CRUK was about 17 to 22% at stage 4. But that's quite different for different subtypes of metastatic breast cancer. So you can get estrogen receptor positive breast cancer, which actually people can have metastatic disease with just in the bone, for example, for many, many years. So it's quite different depending on the subtype. The final part of that was there any more? Can we ever...
Can it ever be cured?
I think the answer to that is absolutely, because I have hundreds of patients who have been treated in the Cambridge Breast Cancer unit who have not had their cancer back. So I think the answer is yes.
Can I ask a supplementary question, kind of prompted really by that question, which is that, I mean, we recognise that cancer in all its forms is the sort of disease that causes profound anxiety and psychological. It's not like, so to speak, I'll oversimplify this because there will be people, but if you break your finger, you're by and large going to hope that you're not going to worry permanently, whereas cancer is not like that. It creates an anxiety. Does the development of precision medicine, do you think is that going to affect that sort of sense of anxiety over time, positively affect it, or is it or do you see that anxiety part of it continuing to be the case for the foreseeable future?
I mean, I would hope that we can allay some of those anxieties, because one of the things that patients most often ask after they've had all their treatment is, how will I know if the disease is coming back? And things like circulating tumor DNA, more sophisticated ways of imaging people, those types of areas will really help to highlight which patients we need to be screening more frequently if the disease is beginning to recur, so that we can implement a treatment earlier, so that we can actually stop the disease progressing. So I think those kind of things will help alleviate some of those anxieties. But I think fundamentally, if you are a cancer patient and you've just finished your treatment, it lives with you for quite a long time, that anxiety. And I think that's something that we just have to be respectful of. I think the patient who inspired the partner trial was a 27-year-old girl who, for the first 2 years after she finished her treatment, emailed me or rang me almost on a monthly basis. But now she is, so that's 2012 probably, so she's now a good, nearly coming up for 9 years out, or 8 years out from having been treated, and I haven't heard from her for the last 6. So it takes a while, but you get there.
Good. Thank you, Jean. Nikki, sorry to interrupt you.
No, then there's another question. The hypermutation mentioned in one of these case studies, was this present in the germline or somatic genome, or both? Please excuse if I've pronounced any of that incorrectly.
That's right. So the hypermutation was present in the somatic, so in the tumor, but because we don't routinely scan for, genetically test for the inherited version of the gene that was abnormal, so it's not a standard breast cancer risk gene, it's not something that we would have routinely picked up usually. So the hypermutation in the tumor made us look closer at her genome, both germline and somatic, and there were changes in the germline actually then led us to do the extra screening, but the hypermutation was in the tumor DNA.
Okay, and then there are 2 more questions that have come through to the Q&A.
Yeah.
One from Nikki, who says, how can you tell if it's a reoccurrence or new disease?
Well, that's a good question. So timing can sometimes help that. We test the tumor to see if it has a similar set of characteristics to the first onset of the cancer. So if, for example, you're a triple negative breast cancer patient and you've relapsed very quickly, then very often it's quite obvious that it's a relapse. It becomes more difficult if you relapse 3, 4, 5 years later. And then you really have to look into the nature of the relapse to see if it is related to the original cancer or if it's a new cancer.
Thanks. I mean, I'll pick up the final question so far that's been from Siva, and I mean, it may be, Jean, that you're not able to answer this specifically. I may want to take this up directly with Siva herself, but I'll read the question. This was just a note from Siva saying, my late husband had breast cancer and it came back after 12 years and went to his brain unnoticed, and he died after 2 years. So Siva, we're very sorry about that. But your question is, should your son, Siva's son, get checked under your study? So you may not want to answer some of that because it may depend on lots of particulars, Jean, but do you want to what would be your initial reaction?
So because the personalised breast cancer programme is for patients who already have breast cancer, assuming that hopefully Siva's son does not have breast cancer, he wouldn't be eligible for it. Depending on what was done at the time, I don't know if, and this is obviously a conversation perhaps we need to have offline, whether there was any genetics referral made at the time her husband was diagnosed, or whether there is any other family history that might give weight to getting her son additionally tested. Those are the kind of questions that we need to explore a bit more in terms of further testing.
Thank you, Jean. So Siva, at the end, Nikki will tell us how, if we've got particular questions, how to communicate with us, and then we can take those further forward with you helpfully in a way that would be helpful to you. So I hope that's okay, Siva. Nikki, any other questions on Facebook?
No questions on Facebook. Actually, there is one here that says, please define again precision medicine in a layman's terms.
Okay.
If you could summarize it as quick as you can as basically as you can, I suppose.
Okay, so it's really finding the right treatment or management option for any one individual at a specific point in their cancer care. So the right drug for the right patient at the right time, I guess, and individualized or developed for each person, and not as a block just because you have a couple of particular biomarkers. So it's looking at the person, both what they've inherited and what's developed with their cancer, and deciding based on the features of that what the best treatment options are.
Lovely. I think that's very clear. And then there's just one more question from Sean that we see in the Q&A. We see reports that COVID is having an impact on diagnosis of cancer in general due to a lack of screening, reduced GP referrals and reduced diagnostic scanning, as well as reduced treatment options being available. As a result, what impact are we likely to see on patient prognosis in future years?
I mean, Sean's an expert on tough questions, I think. So that is a tough question, but a really good one, because I think that's a question that many studies, I mean, there are literally hundreds of COVID studies, both in cancer patients and outside of cancer patients. So I think that's a question that we will be able to answer in the future. But I think our pathologists might tell us that perhaps cancers are presenting with slightly larger than we would have expected, maybe more advanced than we would have expected. So in terms of prognosis, potentially if people present with slightly more advanced cancers, whether it's in terms of local spread or distant spread, then obviously that might affect how long they survive going forward. So I think that's a question that we will be able to answer in the longer term, but certainly Sean is absolutely right. It has the potential to affect patient prognosis, both in terms of survival and relapse. I would say,
if I add to what you're just saying there, Jean, the comments I made earlier on about coming into hospital or presenting yourself, I think we did see in April and May delays in patients presenting themselves. They said, well, I'll just keep an eye on it, I won't, and that was a worry to us because the later detection compounds the problem, and that's something that has been a factor for us. Likewise, and it's not just unique to cancer, it applies to other conditions too, where people have then had their treatments delayed, even if it's been detected, and that then has made that the condition has worsened. We've been very clear that we're trying to take a very clear prioritization approach to this, but it is a worry. But Jean, do you want to add anything further?
Yeah, so just to go back to the breast cancer side of that issue, we have done a specific COVID study run by one of my clinical fellows and one of our data and coordination team on the breast cancer unit and the impact of COVID, which we'll be publishing. The oncology department has a broader project as well, which they are publishing. So we will have quite detailed information. But one thing that we did realize during that data gathering exercise is that actually of about 450 patients who one way or the other came through the breast cancer unit, only 4 patients were tested COVID positive. And actually of those, I think only 1 or maybe 2 were admitted to hospital, and we had no deaths from COVID. So it is really important to reinforce the idea that, whether it's coming to be diagnosed or coming to be treated, that you shouldn't, ignore symptoms, and don't be too frightened about coming for treatment. We have brilliant nurses and clinical staff who can guide you through the precautions you need to take, and those numbers tell us that actually the risks are quite low.
Thank you, Jean. I'm very conscious that we put coins in the Zoom and Facebook meter at the beginning of these sessions, so the coins will run out in about 5 minutes. So we'll come through some concluding questions, and then I'll hand over to Nikki, who can make sure that we pick up how we're going to deal with any questions that we don't have the time to answer. But I've got one here from Carol, which is how is the cancer with no tumour but the skin soreness, which you mentioned earlier on in your presentation, how is that identified?
Yeah, that's a really tricky one, and it's quite an aggressive cancer as well. So that's called inflammatory breast cancer, and basically it's usually found by the patient. So it's usually found because they feel that their skin is hot and red and feels a bit inflamed or tough to the touch. And it's not because they find a specific lump in a particular area. So that it is actually usually found by the patient, and it is a cancer that we have to treat quite quickly and usually quite aggressively in terms of treatment options.
Thank you, Jean. Nikki, I think I've run out of questions I can see. Have you seen others on Facebook, or do you want to guide us through what they remain?
I think that's it for now. I actually think we've answered all of the questions. There are some I think that we could sort of give a little bit more detail to, which I will then collate those questions and send them on to the right people for answering, and then get back to everybody. But yes, I would like to thank everybody for joining us, especially the members. We really appreciate your support, and we are so thrilled that you are enjoying these talks.
Thank you, Nikki, and thank you to you for organising them. I mean, I always feel in very safe hands here, so thank you, Nikki, for that. Just the question from Siva, I think it was. So you've got everything you need to be able to make sure that if there are any particulars to follow up separately, we can do that.
Yes, we can. So no one's asked any anonymous questions. So we've got details and email addresses. So we will email everybody directly.
Excellent. Okay. Well, I think it just, for me then, to conclude the session, first of all and primarily to thank Eugene for an excellent presentation and talk, which is very clear and I think has informed us all, and judging by the answers and some of the comments, assured many people as to this. So thank you to you and of course the whole team for all the work that's happening here in Cambridge to assist this, and I know it's vitally important to so many thousands of people across the country. So thank you to you. Thank you, Nikki, for organising this and making it work run so well. So I really appreciate that. And thank you to all members who are watching either now or will be watching later on when you look at it later on the CUH Facebook page. So it will be available for people to look at later on. We know that people do come back to these and look at them in later weeks, and that's all part of the process communication. So thank you to everyone. I wish everyone well, and obviously we're going through another phase of lockdown, and I wish you and your families and friends all best wishes through this period, and as we emerge hopefully out of 2020 into a new year later on. So thank you to everybody, and thank you for your support to Addenbrooke's Hospital. I think I can say on behalf of Jean and all our clinical colleagues throughout the hospital, representing all parts of the hospital and all services that we provide, that we're deeply, deeply appreciative of the support of members and the public to what we're doing. So thank you for that. So good night, and I hope everyone has a good evening. Thank you. Bye.
Bye.